Bismillah ar-Rahman ar-Rahim. I would like to thank the organizing committee for inviting me here to this magnificent place. Dr. Kohla, Dr. Gasser, the chairpersons. Really, I think this is a very good venue for congresses later on. Today, حاولت ان انا يبقى المحاضرة more of like short notice messages for challenges and maybe some mistakes in judgments as regards transplantation for HCC as I was asked to present. And maybe before I start, maybe I see that one of the biggest challenges is to pursue a career in a liver transplantation, but that's something too late to change now. First thing, for our patients, I think sometimes you can judge your patient as if he's too old to be transplanted or he's too obese to be transplanted and he having an HCC. The dilemma of having the ethical, that we depend on the living donation program, and there is some young adult who will donate for like 60 years old or 65 years old patients. And I have to tell you that don't judge by numbers. The chronological age is not so important. We have the clinical age, which is very important. And we don't have to say that maybe the 70 years is the age that we can say afterwards, maybe he's too old to get a new liver. But the physiological age is more important than the number of the chronological age. And up till now, we keep this for the age, for the MDT discussion, for case by case, for any patients, he's reaching this number. But the major challenge, if you have a patient with an HCC, that he has a high BMI. It's not so uncommon. Usually the patients with an HCC, with chronic liver disease, are sarcopenic, as we will discuss later on. But sometimes now we get patients who have a high BMI. And if you are depending on living donation, you have to have a right lobe that can fit this patient to have a graft recipient weight ratio that is matching. And this is a dilemma. And even in the Western country now, they are discussing some weight reduction procedures for that. But still, this is a big challenge. If you have an HCC patient, he's willing to transplant, he has some donors, but the graft recipient weight ratio is not matching, and you cannot transplant him because he's too obese. So this is still an obstacle and a challenge that can prevent our patients from getting transplant. On the contrary, you can get your patient in a sarcopenic state. And those patients needs accurate assessment, because most of the patients with decompensating liver disease, they're not paying much attention to your nutritional status. So when he develops an HCC, he's in a poor nutritional status. فإحنا في الأسسمنت بتاعنا we have to include the CT scan, the sarcopenic assessment, and we depend on the skeletal muscle mass, or skeletal muscle index at the level of lumbar vertebrae 3. And this is very important. And you have to combine it مع some tests اللي هي الgrip strength, chair standing and balance. This is very important because you have to improve this in your patients in order to be fit and have a good outcome after transplant. So this is a general challenges you can face for your patients, the age, the BMI, whether it's high or sarcopenic patients. The main dilemma and challenge usually comes from selection of the patients, if they are within the Milan or without the Milan criteria. Usually in the LDLT settings, it's quite different from the cadaveric settings, because the LDLT is a personal gift. There is a donor from the family that's giving a gift to the recipient. So a lot of expanded criteria have been done, and you can see a lot of centers all over the world expanding the Milan criteria and publishing that they have an accepted rate comparable to the benchmark of the Milan criteria. Not only the size and not only the number, but some biological factors are included in this criteria in order to assess the patients. But all of them, they agree that there is some price to pay if you go beyond the Milan criteria. So we have incorporated not only the number and not only the size, there is some other factors as we will discuss later. لازم يكون في بعض الجادجمنتالز ان احنا نقول لما نعدي الميلان كرايتيريا نبقى احنا مطمنين ان الاكسبتد ريكارنس ريت بتاعنا كويس. لكن still we have contraindications مش هنقدر نتعداها. ما زال الميجر فاسكولار انفيجن اللي هو الماكرو فاسكولار انفيجن وات ايفر بورتال فين ثرومبس هيباتيك فين ثرومبس، وجود الميتاسيس بكل انواعها، الرابتشر اتش سي سي، والجنرال كونترا انديكيشنز اللي هو الانكونترولد سيبسز او الانكسبتد كوموربيديتيز فور سيرجريز. دول هيفضلوا كونترا انديكيشنز زي ما هم. لكن نيجي بقى للتشالنجز للعيان اللي هو maybe beyond Milan او we want to keep him within Milan. One of the markers that has been involved now is the alpha-fetoprotein. They used to consider it as a biological marker of aggressiveness. So it is very important to have your alpha-fetoprotein. In the past, we used to have it below 1,000. Now we don't accept alpha-fetoprotein which is more than 400. So we tend to do, even if the patient is within Milan and he has an alpha-fetoprotein above 400, we do some procedures in order to reduce the alpha-fetoprotein to below 400 before transplantation. So this has improved the outcomes. One of the key major players is the locoregional therapies. These are the things you can do in order to reduce the alpha-fetoprotein. And I have to say that the locoregional therapy has now not considered bridging as they are used in the past. In the past, we tend to use the locoregional therapy to get patients who are outside the Milan to within the Milan. But now, even the patients within Milan, we can use the locoregional therapy as a selecting tool. We can see the response. This is like a biological test. This is like the oncologist when he gives chemotherapy to the tumor before surgery, neoadjuvant setting. So this is a very important concept. We tend to use it a lot if the patient, even if he's having a donor and he's on the pipeline for preparation, we tend to give him some locoregional treatment and continue in his preparation. So locoregional treatment is a very important selection tool. And this has changed the concept of the term downstaging to the term of neoadjuvant. Downstaging if the tumor is beyond the Milan, I want to bring him within the Milan. But neoadjuvant, he's within the Milan, but I want to select the good candidates from those who within Milan. So this will lead to much better outcome in your transplant in the form of the long-term survival, the recurrence-free survival. So we tend to use that more in the neoadjuvant setting more than the downstaging settings. We all know that the locoregional treatment, they will not cure the condition, but those responders are better candidates for more curative options of transplantation. So if the patient is candidate like for locoregional therapy, transarterial chemoembolization, he will do it. If he's candidate for the radiofrequency ablation, he will do it. These are the two commonest procedures to be done. And there is a lot of variations and there is a lot of protocols in different centers of how to bridge and how to use them in the neoadjuvant setting. Every center put its own protocol and every patient is discussed in the MDT discussion. And there is a lot of combination whether to use the modalities of treatment. Point number 4. The way to assess, the challenge to assess if this patient has an extrahepatic disease. This is very important because we tend and we are obliged to do the PET scan. And unfortunately, the PET scan is not the best tool in the HCC patient because although it gives us sometimes takes the radioactive material, some other maybe lesions will not take the radioactive material and they are HCC. We don't depend upon the number, we don't depend upon the site, we only want to see that if there is an extrahepatic disease. So please don't order PET scan to assess liver tumors, whether the number or the activity. This is useless. We only tend to order the PET scan for the extrahepatic disease. And the main dilemma, if you get lymph node affection. Lymph node affections sometimes are very problematic because the criteria in the CT, maybe they are enlarged, they are not typical. The radiologists say that there is a suspicious node. So if there is a node, you consider in extrahepatic, so you will deny him from doing transplantation. So the assessment of lymph node is very important because frequently those patients who have hepatitis C and liver cirrhosis have enlarged nodes, hepatics and around celiacs. So accurate assessment is very important for those nodes, and you have to consider that those patients should not be denied transplantation for only having nodes. You can prepare the patient, he will go into surgery for transplant, the recipient will go first, you take the node out, you have a pathologist in there, if the nodes are negative, you will continue your transplant. So if the nodes are not frankly 100% malignant in the radiology, and even if you can biopsy them, you will do a biopsy, but don't deny the patient's transplantation only for PET positive nodes. PET positive nodes are nonsense. The fifth challenge is the patient with the portal vein thrombosis, non-malignant. If he has an HCC and he has a portal vein thrombosis, this is very important. I get you this challenge because a lot of the patients, you confront them, and sometimes there is a dilemma whether to give anticoagulant therapy for them or not. Well, please do give them anticoagulant therapy because we don't want to have a lot of patients having grade 4 portal vein thrombosis, very problematic, increased risk of transplantation and increased mortality. So we don't tend to transplant patients with grade 4 portal vein thrombosis. So sometimes a patient with a curable HCC needs transplantation, but he has grade 4 benign portal vein thrombosis because he missed a chance of being treated early on. The same is that the problem gets from the coagulation profile. You are afraid to treat those patients because you are afraid of having bleeding, varicose bleeding, and later on, and the use of the thromboelastometry is very important in order to encourage you for those patients to select those who will benefit from the anticoagulant therapy. So please do incorporate this instead of the static PTE and PTT assessment for the coagulation profile of the liver transplant patient, because this will give you a dynamic process of coagulation and will guide you whether to give anticoagulants for them. The last challenge is that we will not stop for the HCC for the transplantation. This was an absolute contraindication to transplant the patients for metastasis. Now there is a lot of consensus, and there is some what we call guidelines when to transplant colorectal liver mets. And this is a breakthrough because this was a complete contraindication. We have now an algorithm published in the International Hepatobiliary Association, how to select for those patients. There is a lot of studies that is going on now. The most important of them is what we call the TransMed study. This is a randomized control study. This is a randomized control study. Will give us level 1 evidence. We will expecting the results in February 27, 3 years from now. And the early results are encouraging. And if this study will give us a survival benefit for those patients, maybe in the next coming 3 to 4 years, you will hear about transplantation for the colorectal liver mets in special criteria and special indication we will not discuss. So today's mistakes may be tomorrow's future. The take-home message, the liver donor liver transplantation is a robust treatment pathway for an HCC. The employment and the dynamic application for the selection criteria is the cornerstone for the best outcome. The number and size of the tumor are not the only factors to consider for patient selections, but there is some other factors you have to consider. Most of the transplantation centers combine biological factors in addition to the treatment, in addition to the size and number. And thank you very much.
Thank you very much, Professor Ahmed, for this interesting presentation about the practical challenges in liver transplantation. Any comment or question? I have a small question about sarcopenia. You mentioned sarcopenia. In your center of liver transplantation here in Alexandria, what do you do for sarcopenia?
We have a dedicated nutritionist. All our patients in the follow-up programs or during the outpatient clinic, they have to go to the nutritional consultation, and he follows with them the schedule, and he weights them and prepares them while they're doing the labs and the radiology and
Why sarcopenia is a problem before transplantation?
because the patient in the liver disease, the myth, don't eat proteins, don't get a lot of, so he's not
And
moving.
the patient post-operatively will not be moving, will be bedridden, have many complications.
Yes?
Yes, you are right. Thank you, Professor Ahmed. Any more comment or question? Thank you.